You have to unmute, ma. Your mic is muted.
Yes, sir. Sorry, sir. Good evening, sir.
Good evening.
My topic is principles in.
Yeah, go ahead. Go ahead.
My topic is principle in regional anesthesia in children. Introduction. Pediatric regional anesthesia helps to ensure optimum analgesia and decrease postoperative pain in children. It is opioid sparing and it reduces the dose of general anesthesia requirements. It may be used as a sole anesthetic or used with minimal sedation. Understanding the difference in anatomical, physiological, and pharmacology between adults and children is essential. Using ultrasound guidance, it decreases the risk of any nerve or vascular injury. To avoid life-threatening local anesthesia systemic toxicity, we have to calculate the maximum recommended dose of local anesthesia should be calculated prior to administration. Anatomical differences. In CNS, the rate of growth of vertebral column exceeds the spinal cord. While performing neuroaxial block, surface landmark is essential in children to decrease the risk of any trauma to the spinal cord. Termination of conus medullaris in adults ends in L1, in infants in L3 to L4. Termination of dural sac ends in adults S2, in infants in S3 to S4. Tertius line, it crosses adults L4 to L5, in infants L5 to S1. Subarachnoid block should be performed below this level to avoid direct trauma to the spinal cord. In adults, there is thoracic kyphosis, lumbar lordosis. In infant, single spinal curvature with high density of flexibility. The bones are ossified in adult, but in neonates, there is cartilaginous bone. So it is increased cephalate spread of local anesthesia due to lack of lumbar lordosis, and sharp needles may traverse into the bone, damaging ossification nuclei. It increases the risk of intraosseous local anesthesia injection. So we use short bevel blunt tip needle can decrease this risk. In sacral bone, fusion completes by 25 years of age. In neonates, it is incomplete. In sacral, hiatus is a portal of caudal injection until 6 to 8 years of age, when fusion typically begins. So, sacral epidural approaches until fusion complete. We will use up to 12 years of age. There is less epidural fat and increased fibrous tissue, firmly attached fascia, sheath, aponeurosis in adults. In neonates, it is epidural fat loosely attached with fascia, sheath, and aponeurosis. That ligaments are well densed in adults, in less densed in neonates. In neonates, it is easier to thread epidural catheter several centimeters along the epidural space without resistance. CSF volume, adults in 2 ml per kg, whether in infants 4 ml per kg, in children 3 ml per kg. CSF volume in spinal canal relative to intracranial space is 25% in adults, while 50% of spinal canal in neonates. In neonates, there is requirement of a larger volume to achieve a high quality block. Loss of resistance is subtle as compared to adults. In children, there is local anesthesia systemic toxicity is faster than adults. Autonomic nervous system, it is well matured in adults. It is immature in children, because the immature sympathetic nervous system and the peripheral nervous system dominance is reason. In children, peripheral vasodilation and hypotension are less common when compared to adults while performing the regional blocks. Complete myelination in adults, whether in immature in neonates. Vascular surrounding nerves in less vascular in adults is the risk vascular is rich vascular in neonates. Local anesthesia rapidly penetrates the nerves, producing faster onset block. A low concentration of local anesthesia can achieve high quality of dense block. Local anesthesia choice. Amide local anesthesia are frequently used. Either levobupivacaine or levobupivacaine. It is less cardiotoxic than bupivacaine. If we want to choose Eastern local anesthesia, we can go for chlorprocaine or procaine can use. It is metabolized by plasma cholinesterase. Pharmacokinetics in children. Absorption, that is in children, that is high cardiac output, low tissue binding, resulting in higher rate of systemic absorption. It results shorter duration of local anesthesia action and increased risk of local anesthesia systemic toxicity. Distribution, neonates have high volume of distribution, high extracellular fluid volume, and a low alpha-1 acid glycoprotein in plasma, and the increased unbound fraction of local anesthesia in the plasma. So in children, higher dose requirements and higher unbound fraction, it leads to local anesthesia systemic toxicity. Metabolism, lignocaine and bupivacaine, earliest it can metabolized by cytochrome P 3A7, and in 9 months of age, it can metabolized by cytochrome P 3A4. Ropivacaine and levobupivacaine is immature until 3 years of age. It is fully developed by 8 years of age. It is its half-life of made local anesthesia in neonates 3 to 8 times longer than adults. We have to calculate weight-based local anesthesia dose calculation before performing the block. In ropivacaine 3 mg per kg, bupivacaine 2 mg per kg, levobupivacaine 3 mg per kg, lignocaine 5 mg per kg. In chlorprocaine and procaine is 7 mg per kg. If you are using adrenaline, it is 10 mg per kg in lignocaine. Lignocaine with adrenaline is 10 mg per kg. Additives, routinely not recommended. Sometimes we can use clonidine 1 to 2 mg per kg. Dexmet is 1 mg per kg. Adrenaline is not recommended due to spinal cord ischemia. Peripheral nerve catheter. A peripheral nerve catheter, it allows continuous analgesia for acute pain such as post-operative pain, ischemic pain, ambulatory pain. It decreases the opioid requirements and opioid side effects such as nausea, vomiting. Peripheral nerve catheter advantages. Prolonged duration of analgesia, yearly ambulation, and shorter hospital stay. It can be left up to 7 days. Complications, catheter-related infections after fourth day of post-op. It can be failure or migration or blockage or leakage. Any skin reactions. We can, while performing epidural block, in a loss of resistance, we can use saline or air or both. In a loss of LOR to air associated with air embolism or air trapping or nerve root compression, subcutaneous emphysema, and pneumocephalus. The total volume of air injected should not be exceed 0.5 to 1 ml. LOR to saline can dilute local anesthesia. Large volume of injected may cause transient cerebral blood flow. It may be more difficult to identify a dural puncture using this LOR saline. Patients with pre-existing neurology conditions. In patients with pre-existing neurology conditions affecting cardiac and respiratory function can be affect. Can be beneficial for analgesia, minimizing opioid-related ventilatory impairment and minimizing hemodynamic disturbances related to pain after surgery. That is no absolute contraindication to performing a block in pre-existing neurology conditions. Safety profile. Ultrasound allows visualization of the needle tip and spread of injected local anesthesia, minimize the risk of inadvertent injury to any vascular or organ structure. So ultrasound results in faster onset, increase the duration, increase the block density, and reduce the local volume requirement. Test dosing. A test dose containing local anesthesia, adrenaline, or both to identify inadvertent intravascular needle placement. A pediatric test dose is 0.5 mg per kg of adrenaline. A positive test dose is defined as increased heart rate more than 10 heartbeats, increase in systolic blood pressure more than 15 mm of mercury, or 25% change in the T wave amplitude or ST segment size. Local anesthesia systemic toxicity. While performing a regional block under general anesthesia or deep sedation, the early sign of lost or cardiovascular, including peak T waves, dysarrhythmias. Infants less than 6 years are more high risk for loss due to unrecognized intravascular injection, rapid absorption, distribution of local anesthesia, and decreased level of alpha-1 acid glycoprotein. Take home point is we have to, in using ultrasound, it's a better visualize for decrease the local anesthesia systemic toxicity, sir. And careful local anesthesia dose calculation should always be performing before block, sir. Thank you, sir.
So you started off well, but lost your way in between. You went on to go for some
Yes, sir.
things which are not required for a theory answering.
Yes, sir.
So the question is basic principles of pediatric regional anesthesia.
Yes, sir.
So, as you rightly said, there are a lot of anatomical changes in the whether you perform central neuraxial blockade or regional blockade. There is a lot of anatomical differences in the between. You need not be always comparing it with the adults. You can
Okay,
just
sir.
mention what are the differences or how they differ in a child, in a pediatric patient.
Okay, sir.
Especially when you want to do anything in the vertebral column. You must know the anatomy, where the spinal cord ends and how it reaches a higher level as the child grows. What is how the caudal epidural is much more easier to perform because of the thin sacrophalangeal membrane and easy bony landmarks to identify that place. And when you mention about the local anesthetic toxicity, what is the most important difference in the local anesthetic toxicity exhibited in pediatric patients? Supposing an adult patient exhibits a local anesthetic toxicity, what will be the first symptom in an adult patient?
Numbness, oral and nausea.
Perioral numbness.
Oral numbness, sir.
Okay. So is it a central nervous system effect or a cardiovascular system effect?
Central nervous system, sir.
Central nervous system effect. So once the patient exhibits the central nervous system effect in the form of perioral numbness, tingling, some sort of excitation initially and then depression, when will the cardiac symptoms occur? Immediately or little later?
To 10 minutes of 20 minutes of.
So not 20 minutes, but it may take a gap after the onset of nervous system effect. You get the cardiovascular system effect at least with a gap of 5 to 10 minutes later on. So it gives you a caution or time to identify that you are causing a systemic absorption and toxicity, and you can stop injecting further medication and prevent the cardiovascular effect occurring. Okay, that is the advantage of local anesthetic toxicity in a adult patient. Whereas in a pediatric patient, both the central nervous system effect and the cardiovascular system immediately they occur together. They don't occur at a different timings like this in adult. So if you are not careful in choosing the correct volume and the concentration, and if you are not able to identify an accidental intravascular injection, then you can land up with a local anesthetic systemic toxicity, which will result in both neurological as well as cardiovascular effects like bradycardia, hypotension, and cardiac arrest together. It will not be separate like an adult. So that is the reason why you have to be very, very careful in a pediatric patient when you use this drug. So I will just show you how to present this answer
Yes, sir.
in the exam.
Yes, sir.